I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, everyone, and welcome to the September 2017 edition of the PRS Journal Club podcast. My name is Jordan Frey, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Shuja Shafqat from Lehigh Valley, now at Fox Chase Microfellowship, and Chad Purnell from Northwestern. Today we have the honor of being joined by Dr. Amy Colwell, Associate Professor of Plastic Surgery at Harvard Medical School and Massachusetts General Hospital. Thank you very much, Dr. Colwell, for joining us for this PRS Journal Club podcast.
Thanks so much for having me.
And the article we'll be discussing now is entitled Macrotextured Breast Implants with Defined Steps to Minimize Bacterial Contamination Around the Device, Experience in 42,000 Implants. And this is from Dr. Adams and colleagues from UT Southwestern. And remember, everyone listening, all of this month's articles can be read for free on prsjournal.com, and that includes an archive of all past Journal Club articles. So to kind of give an introduction of this article, the authors begin by discussing that there's data that chronic inflammation from bacteria and biofilm has been associated and postulated as responsible for the development of breast implant-associated anaplastic large cell lymphoma, or BIA-ALCL. And to date, all confirmed cases have been in patients currently with or having textured devices in the past. There are other cases in patients with unknown type of implants, but all of the confirmed cases have been with textured implants. And the texturing on these implants varies and is generally classified as either macrotextured, intermediate textured, or microtextured. And the authors discuss that macrotextured implants tend to harbor more bacteria, which can form a biofilm and may incite a greater chronic T-cell response, which can play a role in the development of BIA-ALCL. And so the authors hypothesize that steps, such as their 14-point plan, which I'll discuss in just a moment, to reduce bacterial contamination in these implants would reduce the risk of breast implant-associated ALCL, much in the same way it has reduced risk of capsular contracture, as has been shown. So in order to investigate this, 8 plastic surgeons from 5 countries collected their prospective macrotextured implant experience, and this included biocell and polyurethane implants, looking at technique and the incidence of BIA-ALCL. And the data was combined and pooled for the 8 surgeons in the study, and each surgeon's adherence to the steps of the 14-point plan was also documented. And so to briefly go over the 14-point plan, because that's really kind of the crux of this article, the authors describe it. They use IV antibiotic prophylaxis at the time of anesthetic induction. They avoid periareolar or transaxillary incisions, which may have higher rates of contracture and bacterial contamination. They use nipple shields. They use careful atraumatic dissection, perform careful hemostasis, avoid dissection into the breast parenchyma. They use a dual plane pocket, and they use pocket irrigation with triple antibiotic solution or 1-to-1 dilution or stronger of betadine. They take steps to minimize contamination, such as using a sleeve, funnel, wiping the skin, minimize implant open time and replacement of implant or sizers, change their gloves prior to handling and use clean instruments, avoid using a drain. They use a layered closure, and then give antibiotic prophylaxis for subsequent procedures that breach skin or mucosa, such as dental procedures. In terms of results, there were a total of over 42,000 biocell implants placed in over 21,000 patients with a mean follow-up of 11.7 years, and that ranged from 1 year to 14 years. And then there were 704 polyurethane implants that were used in 350 patients approximately, with a mean follow-up of 8 years ranging from 1 to 20 years. The indications for placement were majority primary breast augmentation at about 78%, about 10% were augmentation mastopexies, about 8% revision augmentations, and breast reconstruction represented a minority, only 4% of patients. Their overall rate of capsular contracture, which is not the primary endpoint, was 2.2%, and they know there were no cases, 0 cases of BIA-ALCL. And they also noted all surgeons routinely performed all perioperative components of the 14-point plan at the time of implant placement, while 6 of the surgeons adhered to all 14 steps during placement of about 10,000 implants, being 25%. Remaining 2 surgeons followed 13 of the steps in the rest of the cases, which was about 75%. But the one that they didn't follow was routinely using or recommending antibiotic prophylaxis for subsequent procedures involving skin or mucosa breaks. So in their discussion, the authors mentioned that while designed to facilitate tissue ingrowth and limit implant mobility and malrotation, texturing provides greater surface area, which allows for potentially greater bacteria growth and potential formation of a biofilm. And these biofilms have been shown to elicit a largely T-cell lymphocyte infiltrate. And meanwhile, this chronic stimulation from bacterial antigens can induce a sustained T-cell response and genetic transformation, which appears to be a basic model for development of this breast implant-associated ALCL, similar to that for cutaneous ALCL. And they go into a discussion of similarities and differences between the breast implant-associated ALCL and all of ALCL, including this kind of cutaneous ALCL corollary, noting that this breast implant-associated variety appears to behave more like a lymphoproliferative disorder than true ALCL, given its more indolent course, a lack of ALK expression, and generally it's been confined to seroma fluid and implant capsule, although there have been metastases to the axilla and mediastinum identified in some reports. Typically, they go over treatment, which is generally capsulectomy and very close follow-up. Radiation and chemotherapy have been used in some more advanced cases. And overall, the authors argue that the use of breast implants, especially macrotextured implants, is technically dependent in light of their reports suggesting increased incidence of BIA-ALCL. And they recommend use of their 14-point plan, which has been shown previously to reduce capsular contracture and other sequelae of bacteria and biofilm in implant-based breast surgery. And they emphasize that they observed no cases of breast implant-associated ALCL using these principles. Overall, I thought it's interesting. ALCL, as associated with breast implants, is obviously a very hot topic, and it's imperative that we continue to explore this and kind of define risk. And, they have shown, although this study is not comparative, that using these techniques, a lot of which are intuitive, but putting them together potentially could reduce the risk. I'd be very interested, Dr. Colwell, to hear your thoughts and what you took from this article.
I thought this paper was really interesting. There's been a lot of press and articles about the incidence of the ALCL, and it seems like every article I hear, their incidence tends to increase. So it was interesting to have a paper with no ALCL using the implants that are most associated with it, the macrotextured devices, and using technical principles being able to prevent that. So I thought it was interesting that we had a paper now that uses the textured devices and with such a low incidence of ALCL, because our patients are asking us questions. And now we have another article to show them that there are ways to potentially prevent it when we really feel like they would benefit from a textured implant.
I think those are all really great points, and that brings me to the next question I wanted to ask you. With a lot of publicity and a lot of patients are coming sort of knowing about this entity, how are you counseling your patients regarding risk of BIA-ALCL preoperatively in the setting of any case involving a breast implant? And then as a secondary kind of question, is there any difference in that counseling based on if it's a reconstructive or an aesthetic case, or any changes in your sort of, counseling and practice patterns with these implants?
Well, I think it's really important to counsel the patients when you're doing your informed consent, because now it's in the news and you don't want them to hear from a friend or a family member. You want them to hear the evidence from you. So I start off by telling them that breast implants don't cause breast cancer, but there have been a few women who have developed a low-grade lymphoma around implants. I tell them we're just learning about it and we don't know exactly what causes it, but that it seems to be more frequent in textured implants. In terms of my counseling between reconstructive and aesthetic, the only thing that's really different is that it's pretty rare for me to use a textured implant in an aesthetic case. For reconstruction, there are certain instances where I do like the textured devices, but I feel that with the smooth round ones, the incidence of the ALCL is so low that most women are not very concerned about it. I do tell them that we haven't had any cases where we know that a smooth round implant has caused the lymphoma. They seem to be comforted in that.
I think that's really helpful for us to kind of hear and to navigate these situations, which can be tricky, especially as patients are very well informed about this a lot of times when they're coming to the office. I'm also curious, what is your preferred protocol for these implants, or just in general in cases of avoiding bacterial contamination for infectious and also biofilm and ALCL purposes, and anything that you're doing in accordance with these authors or that you would change based on it? I'm just interested to hear your protocol.
Yeah, I think their 14-point protocol is a good one. I think we can't do all of the 14 points for reconstruction, but you probably could for aesthetic cases. I definitely give intravenous antibiotics at the time of surgery, and that's really just kind of a standard of care protocol. I do avoid the periareolar and transaxillary incisions for augmentations. For reconstruction, it's a little different story. The nipple shields are interesting, and I think that they're probably good for aesthetic cases, but as you know, we're doing more and more nipple-sparing mastectomies for reconstruction. So the nipple's everted, the ductal tissue's taken out, it's all in the field, so it doesn't really make any sense. I think atraumatic dissection is good, but as you know, we don't have all control of that since we're not doing the mastectomy most of the time. Hemostasis is critical in most things. Using a dual plane pocket can have advantages, and more reconstructions are subcutaneous, so we'll have to see how that plans out. I think the triple antibiotic solution is one of the most important things. The bacteria that's been implicated in ALCL is a gram-negative rod, Ralstonia. So as you probably know, our usual antibiotic protocol doesn't cover Ralstonia. So I typically use a dilute betadine solution first, and then I use a triple antibiotic solution, which includes gentamicins, which covers gram-negative rods. So I think that there's a lot of evidence with the triple antibiotic solution and the betadine for both biofilm as well as ALCL. I think steps to minimize skin contamination are good, with either wiping with an antibiotic-soaked cloth or using a sleeve, such as a Keller funnel. And then, minimizing how many people are touching the implant. I always change my gloves prior to putting the implant in. And in terms of avoiding the drains, I think it's a good idea, but again, in reconstruction, we can't really do that. We do take them out as soon as possible. A layered closure, I think, is important just for regular infections. And then the question of whether to use antibiotic prophylaxis for subsequent procedures is sort of debated. We had an infectious disease specialist come to talk to our group a few weeks ago, and they told us if a patient was having a dental procedure, even if it was something like a root canal or something complicated, that we shouldn't need to give them prophylaxis. On the other hand, I've had 2 patients who've had invasive dental procedures who didn't get prophylaxis and then subsequently developed an infection. So I don't know the answer on that one. Those are mostly the things I do. The only other thing I consider is a nasal swab on high-risk patients, such as healthcare workers or potentially someone who's had neoadjuvant chemotherapy, because the bacteria that reside in their skin may be different than someone else.
I think those are very thorough and really great points, especially for us as we're kind of learning and doing these cases of standard techniques that we should be aspiring to. Shuja, I'm curious, what did you think about this paper?
I agree. I thought it was an interesting paper. I like that it went into some of the science behind bacterial biofilm and capsular contracture and ALCL. Certainly, I see their 14-point system. There are some instances where I think, dissection in the breast parenchyma can be avoided, certainly in cosmetic cases like augmentation mastopexy, depending on how you do them. That may go out of order, but that may change some people's minds with this paper. I agree with Dr. Colwell about the antibiotics for subsequent procedures. In my experience, never done it in residency, but it may be something to think about, particularly in patients who may be high risk or for developing infections. but certainly it's a huge number of implants. It's hard to argue with that much data over that long of a time. So it gives us good confidence in the results, and it's possible more information, more instances of these complications could come about, in a longer follow-up period, even though their follow-up period was pretty good. But overall, I thought it was a pretty good paper. So my question to Dr. Colwell is, does this article reassure you in any way regarding macrotextured implants? Does it change how you think you might practice or choose implants, or does it not really change your current protocol for what you choose?
I think it basically reinforces what I've done. Textured implants were never the majority of my practice. I always had to have a reason to use them. So for patients with really thin skin, I think that potentially texturing may have an advantage if a patient needs to get radiation. It may have an advantage in a patient with ptosis in terms of nipple elevation. So I've always had a reason for using them. The other interesting thing is that we haven't ever had a case at the Mass General. So it's something that I also feel is comforting to patients, and I'm sure we will eventually. But I think that I still feel comfortable using a textured implant, using really good technique, and using it when I really feel it will benefit a patient.
Thank you very much. Chad, what did you think about this article?
I thought this was a good paper. I thought, especially as a resident, this 14-point plan is a good way for me to frame how to absolutely minimize the amount of contamination that's going to touch a breast implant that I'm going to put in. So from that standpoint, I thought this 14-point plan was really helpful and really complete. With regards to BIA ALCL, well, I'm not sure really what to think after reading this paper. I think part of the problem is that this is a very large study with a lot of patients, but I'm not sure this paper necessarily convinces me that the 14-point plan is the reason why none of these patients had BIA ALCL. We don't really know the incidence of BIA ALCL, and this group may not have had it because of the 14-point plan, or because there wasn't a good screening protocol in place, or maybe we just needed to follow these patients up for another couple years and there might have been a case. So I think with regards to the ALCL question, I'm not sure this really answers it for me. And so, Dr. Colwell, that kind of transitions into my question. One of the big problems with BIA ALCL is that we don't really know the incidence of this problem, but we know that it's rare. And so since this is such a rare problem, I wanted to know, what do you think are the best ways for plastic surgeons to build their knowledge about this disease? Do you think there should be a nationalized database? Do you think we should have another way of sharing information? Should there be a screening protocol a certain number of years after implant placement? I just wanted to get your thoughts.
Well, I think collaboration and sharing is absolutely key. Anytime you have a relatively rare entity, the only way to really learn about it is to share everything you know. You can share specimens to look at it, from a micro standpoint. You can share demographics. So there's lots of different things to put together to try to make sense of it. So I think your idea of a database is good. I think, there's been some groups that have tried to get together and gather all the information so that we know about all the cases, at least as much as we can. So I do think it's really critical.
I think that was a really great discussion, and I think we'll draw to a conclusion there. But everyone, remember to tune in to the other two articles that we'll be discussing on this month's podcast, as well as all of our previous and future podcasts, which we broadcast every month. And don't forget to participate in our monthly #PRS Journal Club on Twitter, where we'll be able to interact with this month's selected articles' authors. And once again, thank you very much, Dr. Colwell, for joining us.
Thank you for having me.